Okay. Well, thank you so much for coming in, everyone, virtually and in person. Um, so my name is Debbie Chen, and I'm an endocrinologist at the University of Michigan. And for this next hour or so, I'll be talking about disparities in thyroid cancer care and specifically why access matters, and some pointers that I wanted patients to be aware of that may be helpful in the thyroid cancer care process. So I don't have any disclosures. And so I want to start off with this quote, which has resonated with me and has simultaneously motivates me to address disparities in my research, which is focused on understanding the components of disparities in thyroid cancer care and factors that contribute to that. So at the convention of the Medical Committee for Human Rights held in March of 1966, Dr. Martin Luther King Jr. had declared that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And so the agenda that I have for today, at least the next hour, is one, to discuss existing disparities in thyroid cancer care, review some of the literature on that. And two is understanding barriers to accessing thyroid cancer care based on the current literature. And then I want to end with what I felt was important for patients to know and specific tips and strategies on the thyroid cancer care access process. So over the last 2 decades, as some of you may know, the number of new cases of thyroid cancer in the US has increased significantly as they have in other parts of the country. And so in 2023, there was an estimated 42,720 new cases of thyroid cancer. And as most patients with thyroid cancer, they do have a good prognosis given the 5-year overall survival is about 98.5%. And so disparities, I think of it as existing across what we consider a thyroid cancer care continuum. And so that often starts with detection of a thyroid nodule, either by palpation or by an imaging study of some sort. And it continues the entire way through to the surveillance phase of monitoring for thyroid cancer recurrence. So when we think about disparities, we think about what are the specific patient populations that are at risk for thyroid cancer disparities. And so this includes racial and ethnic minority groups, including those with limited English proficiency, as well as socioeconomically disadvantaged populations, which includes those with low income, low levels of education, uninsured or underinsured patients. And so when we're talking about disparities in general, specifically about thyroid cancer, I think that it's important to talk and mention specifically two groups. And so one is Hispanic women and two is Asian women. And both of these groups have experienced a disproportionate burden of disease and mortality from thyroid cancer. And so this is a figure that shows that thyroid cancer is the second most common cancer among Hispanic women in the United States. And the same is true for Asian women. And then this is data from the National Cancer Institute that shows that Asian and Hispanic women have the highest thyroid cancer mortality rates in the US. And so despite these two statistics that I'm showing you, in general, Hispanic and Asian women of both sex has remained understudied and underrepresented in the thyroid cancer literature. So to review some of the existing disparities in thyroid cancer care to kind of set a background and have a some understanding in general, I want to start with the diagnosis phase of thyroid cancer. And so studies have consistently found that patients were more likely to be diagnosed with more advanced disease at the time of diagnosis if they were Black, Hispanic, or Asian, compared to patients who were white, if they were from lower socioeconomic status compared to those from higher socioeconomic status, and if they were poor, uninsured, or with Medicaid insurance compared to those with private insurance. And so this was a particularly intriguing study that I had come across. And it's a study of about 470 patients with thyroid cancer after thyroid surgery in 2 adjacent hospitals in New York City. And so what the authors had found, as highlighted in the red boxes on the figure, is that private university hospital patients were more likely to have their thyroid cancer detected by an imaging study, for example, and have smaller tumors compared to those patients with thyroid cancer at a public hospital, which was 2 blocks down in New York City. And then in terms of surgical treatment, studies for the last decade or so have consistently demonstrated the importance of surgeon volume in terms of patient outcome. And so specifically that there's worse outcomes and higher complication rates reported among those who have had surgery by low volume surgeons and institutions. And so this was one of the landmark studies on this topic. And so the authors had looked at about 650 surgeons who performed thyroid surgeries on a total of about 5,000 patients in a hospital setting. The surgeons were categorized by their total volume of thyroid surgery over the 6-year study period, such that the surgeons in Group A performed 1 to 9 thyroid surgeries over the 6-year period. Group B performed 10 to 29 cases. Group C performed 30 to 100 cases. And then Group D performed more than 100 thyroid surgeries over the 6-year study period. And so it's the next couple of slides, and I'll explain why. Yes. So the question was, are these studies specifically related to racial disparities? And not this particular slide, but it sets this tone for the next couple of slides. Yeah, no problem. Thank you for asking. So as you can see in the red boxes that's highlighted, the authors found that the highest volume surgeons are those who was in Group D. They had the shortest length of stay for the patient, as well as the lower complication rates. And so in a different study by the same kind of group of researchers of more than 16,000 patients, they found that the highest volume surgeons in their cohort performed 5% of the thyroidectomies, but 90% of their patients were white. And then the other one, and this is related to the disparities, is that the majority of Black and Hispanic patients in that specific cohort had surgery by the lowest volume surgeons. Okay. So then, as with other conditions, it seems that it matters where patients go for their thyroid cancer. And so one important consideration that patients may encounter is whether to travel or not to an academic center, for example, for the needed medical care. And so in one study where the authors looked at patients with papillary thyroid cancer who underwent thyroid surgery, they found that although there was no survival differences among those who traveled to an academic center versus those who did not travel for their thyroid care, they did find that those who traveled were more likely to have physicians who follow clinical practice guidelines, specifically American Thyroid Association or NCCN, compared to those who not travel for their care. And so there were some differences, even though there wasn't a survival difference. And then in terms of radioactive iodine therapy, which for some patients is part of their thyroid cancer course, studies have demonstrated that there's wide variation between hospitals on the use of radioactive iodine. And then other studies have found that patients were less likely to be treated with radioactive iodine if they were Black, Hispanic, or white compared to, Black, Hispanic, or Asian compared to their white counterparts. And if they were without insurance or with Medicaid insurance compared to those with private insurance or Medicare. And similarly, they were less likely to be treated with radioactive iodine if they had lower socioeconomic status. So the other component with disparities in thyroid cancer care treatment that has been noted in the literature is specifically in terms of clinical trial enrollment. And so clinical trials are very important for patients with advanced thyroid cancer, which is a group that historically did not have great treatment options. And so since 2011, so for the last decade or so, a number of small molecule kinase inhibitors have been approved by the US Food and Drug Administration. And so this was based on the promising data in the clinical trial setting. And so although these trials reported that they recruited patients from up to 164 centers in 25 countries, ultimately the clinical trial patient cohort, so those that were enrolled into the clinical trials, they were predominantly from European and North American sites. And the final cohort was predominantly white patients, as you can see in the figure here, which illustrates the race ethnicity percentage reported in 8 of these 10 clinical trials. You can see that sorry about that. So you can see that the percentage of Black, which is on the far right, as well as other, which includes Hispanic patients, was very minimal compared to those patients who were white, which is on the far left. So then when we move into the surveillance period, which is where you're surveilling for thyroid cancer recurrence, which is where a lot of patients tend to be after the initial treatment phase, there's been differences that have been observed in terms of the patient experience based on non-clinical factors. And so specifically, one of the things that have been talked about in the literature is cancer-related worry, which has been found to be common in disease-free, low-risk thyroid cancer survivors, even 2 to 4 years following their diagnosis. And so there's been other studies that have found that cancer-related worry is associated with being Hispanic or Asian compared to like a reference of white patients. And in additionally, there's been studies that have found that Hispanic ethnicity is associated with overestimating thyroid cancer recurrence risk, which in theory can contribute to some of these cancer-related worries. So before we move on, I want to just kind of highlight a few points about disparities across this thyroid cancer care continuum. So one is that the incidence of thyroid cancer has increased significantly in recent decades in the US and in other countries as well. The second is that most patients with thyroid cancer do have a good prognosis. Third, disparities have been described in multiple aspects, as I have demonstrated, of thyroid cancer care going from diagnosis, postoperative complications, non-surgical treatment, and surveillance phase. And then the last point I want to highlight is that patients from racial ethnic minority groups and those from lower socioeconomic status do seem to be vulnerable to some of worse outcomes. Okay. So the next couple of slides I want to focus on was understanding barriers to accessing thyroid cancer care given the available literature. So when I think about factors that contribute to disparities in thyroid cancer care, like everything else in medicine, I think of it as due to multiple factors. And so this is a figure that is informed by the existing thyroid cancer literature. It's intended to illustrate elements of thyroid cancer care that, when present, contributes to improve outcome. And so it's really inspired by Maslow's hierarchy of needs, which argues that the most basic needs are at the bottom and they must be met before you move higher up on the hierarchy. And so an important one is access to high volume physicians, but also access to thyroid cancer care more broadly. Okay. So there was a major study that had come out in 2021, that showed that disparities exist in access to specialist care. And so not specific to thyroid cancer, but kind of more broadly. And so using pooled data of more than 130,000 patients, the authors found that even after accounting for several social determinants of health, that racial and ethnic minority groups were underrepresented in the outpatient practices of many medical and surgical specialties. And so these are kind of modified figures that I've taken from the study. And it shows that what you're looking at is if the dot is to the left of the line, where the x-axis is 1, it means that there's higher rates for white patients. And then if it's to the right of the 1, then it's either higher blacks for Black patients, Hispanic patients, and Asian Pacific Islander patients. And this physician specialty that I highlighted here is one is otolaryngology or ENT. Sorry. 2 was radiology, general surgery, endocrinology, internal medicine, and oncology. And you can see that a lot of the points in this figure is to the left, indicating higher rates for white patients compared to these other racial ethnic patient populations. So then in a different study that I want to highlight and kind of thinking about access is a study that used 130,000 patients with thyroid cancer and found that 53% experienced care fragmentation, which in this particular study was defined as receipt of treatment at more than one institution or healthcare system. And so what the authors noted was that even though care fragmentation was associated with delays in time to surgery and potentially time to radioactive iodine therapy, it was also associated with treatment at a highest thyroid cancer surgery volume institution, as well as improved overall survival for patients with stage 1 to 3 disease of thyroid cancer. And so when I extrapolate this data and thinking about more care across the thyroid cancer care continuum, it's likely that patients experience care fragmentation kind of at some point from detection to surveillance much more than 53%, especially when you think about the different specialists that a patient may have encountered as part of their thyroid cancer care. And so, for example, as part of the detection or diagnosis, patients may see their primary care physicians, they may see an endocrinologist, they may encounter a radiologist, a surgeon, ENT, medical oncologist. And then for the surgery, if that is what they decide to undergo, you ultimately need to see a surgeon. So endocrine surgery, general surgery, ENT, someone. But then if you end up needing adjuvant therapy, which may be radioactive iodine therapy, it may be like a clinical trial enrollment, it may be a TKI inhibitor, you ultimately may end up seeing endocrinology, medical oncology, and possibly radiology as part of the imaging to really understand the stage of disease. And their surveillance, that also is pretty variable for depending on where you live, who you see. You may see an endocrinologist, your primary care physician, radiologist for the imaging study. And so when you think about how many physicians types of physicians that a patient may encounter in their thyroid cancer care, and the fact that even in there's 53% in some studies, the number of care fragmentation, having care across multiple institutions actually is likely to be higher. And so when I think about access to thyroid cancer care and the steps are required to get there, it actually ends up being a lot of different factors, a lot of essential steps that you have. And so, for example, if you're going to going from the time the clinic appointment is scheduled to the patient physician office visit, like the in-person visit, there's a couple of components that needs to happen. So the patient needs to be able to take time off from work. For example, they need to be able to get transportation to the clinic. They have to physically access the building. They have to have the financial means to afford the clinic visit, like a copay, for example. There's oftentimes paperwork, and so there has to be some component of health literacy. And then if someone doesn't speak English proficiently, there also has to be an interpreter available at that time to really assist with that appointment. So a lot of critical steps that needs to happen even between the appointment being scheduled and getting into the clinic before you see a physician. And then when we think about it more granularly, this is a figure that conceptualizes access as successful passage through multiple access points. And so looking at the one in the far left, for example, if a patient is getting an appointment scheduled, that's the essential step for any clinical visit to establish care with any physician. They may need to have involvement of the hospital operator, for example, to provide the information, provide a telephone number about what number to call. The primary care physician or family physician may have to submit a referral. The clinic staff has to be able to be available to schedule that appointment, and then their health insurance has to be accepted. So even very critical steps, like there's multiple layers to getting access in this case. And so one of the studies that our team at the University of Michigan had found was that at the level of the hospital general information telephone line, so the number that if you were to Google the hospital and at that number to find out information about cancer care services, significant linguistic disparities exist, especially for non-English speakers. And so in this study, we had simulated patient callers call the hospital general information telephone line to inquire about thyroid, colon, or lung cancer services and speaking in one of three languages, so English, Spanish, or Mandarin, which are the three most common languages spoken in the US. And so when you look at the figure that included, compared to the English speakers, which there's getting information about cancer care services is about in the 90%, but when it goes to Spanish or Mandarin, it's about in the 30s and then high 20%. So it's pretty significant from that standpoint. And this was a schematic of the simulated patient caller's experience of calling this hospital general information telephone line seeking to access thyroid cancer care with an outcome of just getting a telephone number being transferred to potentially the correct clinic to provide that information. And so what I wanted to highlight here was that 40% of these calls ended prematurely before the callers were even connected with the language concordance staff or instructions. And so that's pretty notable, I would say. And then when we think more along the access points or like what needs to be done even prior to seeing a physician, prior to physically stepping foot into a clinic, studies have also shown that barriers exist at the level of calling the clinic to schedule a new patient appointment. So this isn't specific to thyroid cancer. I would say it's kind of more broadly applicable to many things in healthcare. But in a specific audit study of 40 NCI designated comprehensive cancer center, research assistants had called the cancer center to inquire about the first available appointment. They identified themselves as a child of a recently diagnosed patient with liver cancer. And what the authors found was that less than 30% or less than a third were able to actually get an estimated or an actual date for an available appointment. And then looking at more non-cancer specific studies, it seems like the barriers to scheduling appointments for non-English speakers are even more greater from that standpoint. So in an audit study in 2005 of 51 New York City hospitals, Spanish-speaking simulated callers called an outpatient clinic to try to schedule an appointment. About a third were not connected to a language concordant staff, and so the call ended prematurely. And then more recently, a 2023 audit study focused on non-cancer care. They found that simulated Spanish-speaking patient callers were much less likely to be able to schedule an appointment compared to the English-speaking counterparts. And so to summarize from that standpoint, so optimal thyroid cancer care, I would say, involves multidisciplinary care from a team of physicians of different specialties working together. And second, I think it's important to note that access to thyroid cancer care in the US, patients need to pass through essentially multiple access points, but they may encounter significant systems level and linguistic barriers when attempting to access such thyroid cancer care. So the question is, were there differences in terms of the insurance type specifically? And I would say that in our study, we didn't look at different insurance. If they were asked for insurance information, it was assumed it was a PPO and then one of the three most common ones. Other studies, not specific to thyroid cancer, has looked at if you had Medicaid versus something else. And it seems like there's not consistently differences in terms of access to that. I think for some primary care potentially, but not necessarily for the cancer care. Yeah, thank you for asking. And so to wrap up, I wanted to focus on, given all that we know about access, given what we know about disparities, what do I think is important for patients to know and, how to go about that? And so thinking of it across the thyroid cancer care continuum, one to start at the diagnosis phase. And so one thing is to definitely have an established primary care physician, obviously because you get regular healthcare maintenance, you get a physical exam that may find a papillary nodule if relevant, but also many times the referral to a specialist in the US nowadays requires a referral. And so the person to put in that referral oftentimes is a primary care physician. And so that helps with that process. Whereas if you call to make a schedule appointment with a specialist, require a referral, and then you have to establish care with a primary care physician, that can create some delays. And then the other thing is the importance of maintaining active health insurance coverage. So, the impact of health insurance, especially in the United States, even nowadays, is because it provides access in many ways. And so in 2022, there was a study that looked at more than 200,000 adult patients with thyroid cancer. They categorize hospital based on their total thyroid volume, surgery volume during the study period. And they found that with the Affordable Care Act, Medicaid's expansion, it was associated, one, with an increased proportion of Medicaid patients undergoing thyroid surgery across all the quartiles, and two, increased Medicaid access to high volume centers in expansion states. And so I would say having active insurance coverage is an important part of getting thyroid cancer care access. The other thing is that if you're calling an endocrinology office or like a surgery office and you're scheduling that initial appointment, I think it's important to have your insurance information, your actual diagnosis, what you were told by your primary care, whoever diagnosed it, potentially a referral, and then also access to your medical records. So specifically the thyroid nodule biopsy cytology report. And the reason for that is that's oftentimes information that some clinics may need to make that referral. And so if you were to call, told you need that information, didn't have that information, it may cause some delays. Whereas if you had it already, that could potentially expedite the process. And then in terms of surgery, so when thinking about thyroid surgery, as you've seen with the data, seeing a high volume surgeon does matter in terms of complication rates, in terms of length of stay, in terms of outcomes. And so what a high volume surgeon means is pretty variable, but it means at least 25 thyroid surgeries per year. And so if someone is doing them every month, it comes out to be about 2 thyroid surgeries per year. And so this is oftentimes a question that I recommend my patients who go outside of the institution ask their surgeons, like, how many thyroid surgeries have you done in the last year? And like, what is your typical volume? And I have asked some other surgeon colleagues of mine if there's a database for this information, because that would facilitate that. And unfortunately, there's not one very public one that I know of. And then when you're calling the surgery clinic, so which surgeon types can perform thyroid surgery is pretty variable, but it often includes like a general surgeon, endocrine surgeon, ENT or otolaryngology are the common ones. And also when you're calling the clinics to schedule an appointment, it helps to have your insurance information, the diagnosis, a possible referral from your primary care, and then medical records, specifically the biopsy reports, I find is very helpful. So in terms of adjuvant therapy, this often refers to if you required radioactive iodine or you were recommended to have radioactive iodine, and or if you had advanced disease and there was consideration for systemic therapy and or enrollment in a clinical trial. So high volume centers are important in that too, as well. And so oftentimes there's like a National Cancer Institute designated cancer center that potentially for some patients could be a good place to start. There's also thyroid cancer clinical trials that may be relevant in your area or not. And so clinicaltrials.gov is a public website that you can try to find information about, and that's helpful. And so this question of, where do you access clinical trials if you fit into one of the categories? And oftentimes it seems that patients do end up needing to travel. So there was one study that I have found that was particularly striking in that it commented that about 80% of cancer patients in general, not just specific to thyroid cancer, but they receive their cancer care in a community setting. And unfortunately, many clinical trials, cancer-related clinical trials occurs in the academic medical center. And so one study looking at a meta-analysis of studies examining clinical trial decision-making pathway, they reported that 56% of cancer patients had 0 clinical trials available for their cancer type and stage at the treating medical center. And so that is why, even though if you get your care at a community setting, for example, if your physicians don't necessarily know about all the other trials, the clinicaltrials.org is a good website to use. The other thing I want to mention is, as with many cancer treatments, patients with cancer are at risk for financial hardship in many ways. And so specifically, some studies have found that thyroid cancer patients are uniquely susceptible. The reasons why are kind of speculated. One, maybe the younger age of patient population, the role of insurance, and other factors as well. And so a number of studies have shown that young age and minority race ethnicity is specifically associated with greater cancer-related financial hardship. One of the studies that we had done, which was a survey-based study of Hispanic women with thyroid cancer from LA, this is the figure that's presented. We specifically asked about financial hardship due to their thyroid cancer. And so this illustrates the distribution of patients who endorse one of these things. And so, for example, 38% report they had to use savings, 25% report they had to cut down on their spendings for food, 18% could not make payments on credit card or other bills, 5% report they moved out of their homes, 3% had their utilities turned off because the bill was not paid. And so you can see that the impact is pretty astronomical in certain aspects as well. And then this is a figure where we look at the impact of age and acculturation on financial hardship due to thyroid cancer. And so in this case, acculturation, we had defined it as a process by which individuals adopt the language, values, attitudes, and behaviors of a culture. We measured it with very much a linguistic, your use of Spanish versus English survey-based questions. And so what you see in this figure is that for Hispanic women with high acculturation, which is the dark gray bars, financial hardship decreases with older age. But then for Hispanic women with low acculturation, which is represented by the light gray bars, financial hardship, you can see, remains elevated across all age groups. And so there are a number of factors that make patients more predisposed or increases their risk of financial hardship. And so the point of that was because some clinical trials, there are some pilots studies ongoing looking at the impact of financial reimbursement programs, and those have yielded promising results. And so hopefully that will get into the thyroid cancer clinical trials as well, the importance of that. And then one of the last things I wanted to focus on was in terms of the surveillance. And so, if someone is having financial hardship related to their thyroid cancer, I think it's always important to ask your clinician at the hospital or your oncologist or whichever specialist you may see about the availability of financial counselor, as well also financial assistance programs, especially to assist with if you needed to travel for your radioactive iodine, for example, if you needed assistance program for the medications, for example, levothyroxine, Levoxyl, and other related medications. And then the other thing in terms of the surveillance is education. So specifically, thyroid cancer patients as a whole have reported pretty significant unmet information needs. And that information needs, when we look specifically at Hispanic women with thyroid cancer with high and low acculturation, that increases if you're looking for resources that are not in English, as you can imagine. And this is kind of more broadly on a website. And so websites or organizations such as the American Thyroid Association, ThyCa, they have resources in other languages such as Spanish, Chinese, and French as well to provide some of that, but it is not like, not everything is there. And so I think if you need resources that are not in English, or you have resources, questions that are not answered by your clinical team, I think it's always worthwhile to ask the clinician, is there other resources that they would recommend? Are there other recommendations they have? But yeah, so thank you so much in person and virtually. I'll be happy to take any questions, but those are my thoughts in terms of what we can do as patients, as physicians, to kind of address some of these barriers to access that contributes to disparities in thyroid cancer care. Yeah. So for the audience who's virtual, so the comment was more the study about the low volume surgeon, and that would have come out, I think. So Julianne Sosa's group had published that study in 1997. And then the study results that showed where there was racial disparities based on surgeon volume, I think that was more in 2007. But that 1997 study has more or less been replicated multiple times over the last 2 decades. And it's very similar in terms of high volume surgeons and the associated patient outcomes. I think ultimately, so for my own patient populations, for the surgeons that I work with closely, I have a good sense of how many surgeries they're doing. I know they're doing whether more than 25 or less than. But oftentimes when patients are more local, if they're driving like hours and they prefer to have it done locally, I think that's very reasonable. But I do give the caveat that I don't know what their volume is, but I do know that there's good data that's been, replicated multiple times about the importance of this number. And this number is anywhere between more than 25 or 100 plus. And so the higher in theory, the better. And so I always recommend to my patients to ask, like, what is your volume? And like how many specific thyroid cancer surgeries you do? Because you could imagine that not every surgeon is doing only thyroid surgeries. And if you're only doing thyroid surgeries and you're practicing, that's great. And you have a good sense. But if a surgeon is doing multiple different types of surgeries and thyroid just happens to be one of them, then that I think is where we come into a lot of concern. And so the comment was this: when you don't necessarily know how many surgeries a physician does or a surgeon does, but when you ask about the complication rates, the lower volume surgeons oftentimes will report higher complication rates. I mean, yeah. And then you can figure it out. I think the hard part of that complications rate is not knowing, like, is 1% high or is it low? Because you don't really have much to reference to. And so oftentimes I will say, if you're going outside of the institution that I'm much more familiar with, to interview a couple of surgeons. So so the reason I have focused on the question is would this data potentially on disparities in thyroid cancer care be different outside of the US? And I think a lot of it ends up being, there's very limited studies outside the US. There's maybe a handful in Canada and some other countries with universal healthcare. But I would say, and the other thing is, the groups, Black, Asian, like they're very specific to the US, and like, what does that mean to be a racial minority in the US? But there are studies outside of the US that do show disparities in thyroid cancer care. For example, there's a study, I forget which country, but there's disparities in terms of who's getting referred to a high volume physician based on age. And so, and then like who's getting access if you're part of the minority group versus my majority group. And so I think disparities exist in other areas. That's my speculation, but I don't know for sure, because a lot of countries, it's illegal to collect race ethnicity data. And so we don't have that data and there's no studies on it. I wish I knew the answer. I don't, unfortunately. The comment was more that the speculation that in areas in countries outside the US that there's more equitable care, but I think that's the hope. I think it'd be very interesting to see like how equitable thyroid cancer care in different like parts of the world are. And so, one would hope that it's as equitable as possible, that everyone who needs access is getting access to thyroid cancer care and by high volume physicians. And I would like to hope that's the case. We wait to see the results. Yeah, so I'm an endocrinologist by training, and so I see patients with thyroid cancer as well as general endocrine disorders. But I also do research very focused on thyroid cancer care and access, as well as disparities and factors. So the question I think you're asking is for patients who are vulnerable to worse outcomes, particularly racial ethnic minority groups, when they're choosing a surgeon, I think based on Julianne Sosa's study, are they choosing particularly low volume surgeons versus are they choosing high volume surgeon, I think is the question. Or do they have and do they have enough information to make a choice? I think that's a very good question, but I don't know that there's been good studies looking at that, because a lot of these studies that I'm citing here, they're database analyses, they're administrative claims database, and so there's not specifically granular data available currently about, for example, I think getting at what you're asking is interviewing patients who are racial ethnic minority group populations with thyroid cancer and asking why did they choose a surgeon that they did, what was the access. I think that'd be a very interesting study. There's just unfortunately not that data available. Yeah, thank you for asking. So I think I'm going to close the chat, but thank you so much for being here today.